Okay, so we're talking about somatoform disorders, and we got 51 minutes, it looks like, to do that. Susan kindly distributed some information that hopefully you've had a chance to review, so I'm not going to go over that in detail, but what I'd like to do is go through the information briefly in the first 10 minutes or so, and then give us time to talk about, I think there's some particularly interesting discussion points about somatoform disorders in general, and then also in specific the conversion from DSM-4 to DSM-5. Go ahead and click for me. So we're going to talk about the history just briefly, and then the nosology, the actual meaning of the terms, and the different diagnoses. We'll talk a little bit about prevalence, about functional consequences, which I think is a particularly important salient point in the context of us working in a more integrated fashion with our primary care brethren. And then we'll talk a little bit about the epistemology, or what is the meaning of a somatic disorder, and is there really such a thing as a somatic disorder, and what does that mean? And then the diagnostic process and the treatment process. And then if we have a chance to work case X in there, I've got a case that I saw as an outpatient consult a year or so ago that I thought might be an interesting one for us to discuss embedded in this agenda. Whether we'll get to it or not, I don't know. I also just wanted to show you how I can do neat little things with PowerPoint like that, so make it look like I did it. Yeah, thank you very much. Okay. So in terms of the history, 4,000 years ago, the Egyptians thought of the concept of the wandering uterus, which may also have been the beginning of the history of misogyny. I'm not sure if that's the case. But then Freud and his buddies came up with the concept of conversion of physical energy into psychic energy, and the conversion disorder was born. DSM embodied, starting certainly with DSM-3, the notion of somatization disorder and conversion disorder and factitious disorder, and essentially from the 1950s until DSM-5, there really hasn't been much change in the diagnostic thinking about somatoform disorders. Let's go ahead and click on, please, Jerry. So the diagnoses in DSM-5 are on the board now, and I underlined the ones that I think are of particular importance in that they are different from those in DSM-4. Conversion disorder, factitious disorder, malingering, body dysmorphic disorder, delusional disorder are all essentially the same as they were in DSM-4. But somatic symptom disorder and illness anxiety disorder and psychological factors affecting other medical conditions are new diagnoses for DSM-5, and so it's probably important for us to spend a little bit of time on those. If you look at the second document that Susan distributed or is distributing, this is an excerpt from the larger document that you guys got in the email that I think does a nice job of going through each of the diagnoses within DSM-5 and converting, showing you the conversion from DSM-4 to DSM-5. So at the risk of spending the whole time talking myself, can somebody share with us what the primary conversion that somatic symptom disorder represents in DSM-4?
Somatization disorder.
Yeah, they're very good. And so what would the differences? I was a high school teacher before I started in medicine, so I'll see if I can rev up some of my old skill set. So what would the differences between somatization disorder and somatic symptom disorder be? Should be fairly easy given that you...
Somatization disorder has that strange and arbitrary cutoff of numbers of systems and so forth.
A lot of different symptoms from different body domains, and you had to satisfy all of them, really, to meet the full criteria. Yeah.
So a lot of people ended up NOS, somatic form disorder.
Right.
NOS, that's where the reality goes.
That's right.
You couldn't diagnose it in kids because most of those also involve the general urinary system.
And no kids, even without that, would ever have enough symptoms to make the diagnosis.
What are the other key differences?
In 4, it had to begin before age 30.
Right. Well, yeah. And I think a primary difference and an important one is the sense that in somatization disorder, there was a requirement that there be some proof that this was not of physical origin. And in somatic symptom disorder, people can have a medical illness, they can have the symptoms, but the requirement is that the psychological reaction to those symptoms is beyond that which one would expect and is causing some functional impairment. And so the writers of DSM-5, at least my understanding is that part of the reason for making this change was, one of them was, speaking to George's point, somatization disorder was such a complicated affair that it was really nebulous for the typical primary care provider, so it just got lost in the shuffle. And so this diagnosis is a much easier one for our folks in the primary care world to wrap their brains around. Not that they're simple-minded at all, but it just is an easier diagnosis. And it doesn't require the exclusion of a medical illness. It's not defined in a negative as somatization disorder was, and thus the effort to obtain a more valid diagnosis is enabled. Okay, illness anxiety disorder. Who can tell me what that converts?
Hypochondriasis.
So what are the key differences between hypochondriasis and illness anxiety disorder?
Certainly less pejorative.
Okay, yeah. Any other thoughts? Scanning your Barlow here, that second handout. This is for the candy now, so come on.
Requiring
an illness as a possibility, probably.
And does this exclude the possibility that you have symptoms, that you have an illness?
I'm guessing no.
No. And by the way, the hypochondriasis could end up being an illness anxiety disorder, but it also could map over to somatic symptom disorder for patients that have some symptoms. So you're kind of splitting up hypochondriasis into two potential diagnoses. Illness anxiety disorder, the writers of DSM-5 state, could be listed under somatoform disorder, the somatoform disorder section. However, it could also be listed as an anxiety disorder. It's essentially an anxiety disorder where the primary cognitive domain is about illness. Okay, psychological factors affecting other medical conditions. What are those? What's an example?
fear of vaccination.
Okay. So, in what way would that satisfy the diagnosis?
Wouldn't that be a simple phobia?
It would get in the way of a treatment.
Okay. So your psychological mindset or your behavior interferes with your treatment of an illness, or in this case, in preventative care. How about the diabetic that, for whatever reason, doesn't want to take their blood sugar? Other examples of that nature that we can come up with?
What about something like irritable bowel syndrome?
Okay, good question, Leah. So irritable bowel syndrome and chronic fatigue syndrome, fibromyalgia, are specifically excluded from somatoform diagnoses. So what does that do for or against these diagnoses? How does that help us to understand them?
Not at all. I mean, those are such politically freighted diagnoses that I think the DSM people probably just took a pass.
Yeah, yeah,
Doesn't help us at all.
right.
But it may take it more out of the psychological realm and more into the physical.
I like it being out of the DSM-5. I guess the way I'm thinking is, it's saying to the medical community, be explicit about how you're going to operationalize the diagnosis medically. And I think there are guidelines for some of those, not others, and some of the guidelines are awfully vague, it seems to me.
Bottom line, we don't know what the heck those things are.
We don't, and that may be a minority view, but I'm glad to have them out of the psychiatric realm. May make it more difficult to diagnose.
Yeah, like a lot of psychosomatic illness, we don't want to own it, but they don't want to own it either.
And actually, I mean, within those diagnoses, you could actually apply psychological factors affecting other medical conditions, and that, does anxiety affect irritable bowel syndrome and make it worse? Are there, other things that could affect those? So.
All right, let's go on to the next slide, please, Jerry. So the prevalence of somatoform disorders, if you refer to your outline, I think that a striking statistic is the first one under Roman numeral 3, that more than 50% of patients that present to a primary care clinic present so without an actual physical underpinning to their complaint. So particularly for those of us that are consulting with the primary care world, that are working on the integrated effort, it's important to be able to have some understanding of these disorders, because whether they get labeled as a somatoform disorder, I mean, not everybody that presents with a psychological complaint, a stress or whatever at a primary care doctor's office is ultimately going to have a somatoform disorder. Nevertheless, having some way of dealing with these essentially non-medical complaints is going to be increasingly important in an accountable care paradigm. So the other actual diagnoses in terms of their prevalence is going to be hard to predict, because these are new diagnoses. For somatic symptom disorder, there hasn't been an SSD prior to DSM-5, and so one can approximate. You can look at somatoform or somatization disorder, which was less than 1% prevalence, and then you can look at undifferentiated somatoform disorder, which was 19%. And then you can approximate that maybe SSD is going to be 5 to 7%, but that's just an approximation.
But that's one of the critiques of it, is that with no prevalence data, no studies to make the diagnosis, how could they actually put this in as a diagnosis? And another critique was there could actually be a much higher prevalence based on the way the criteria are written. So
Sure.
There's been a lot of concerns about this as a valid diagnosis.
Sure. Sure, and I do think that's worth spending some more time on in just a few minutes. In terms of, let's go to the next slide, please. In terms of functional consequences, obviously there can be substantial compromise of someone's overall health status. People can get lots of unnecessary tests and procedures. People spend a lot of money on these resources, 2 to 9 times as expensive as patients without somatoform disorder. Obviously can have troubled relationships with their providers, and in one resource it appeared that there was a 36 to 83% unemployment rate for people with somatization disorders. So these are illnesses that have substantial clinical and financial consequences. Doug and I are in the process of trying to derive a treatment program for the seriously and persistently mentally ill. One of the conversations, one of the points Doug brought up recently was, well, how do you define that? And would you, if you think about this in terms of functional and economic consequences, are there folks with somatization disorder or SSD in DSM-5 that might fall within the rubric of SPMI? Would make it more difficult to have one single treatment program for those folks.
Because they don't play in our idiom. That's the problem.
Yeah. We find them somewhere else. But we're increasingly insinuating ourselves into the primary care world as we should, and so being able to deal with these issues is going to be increasingly important. Next slide, please, Jerry. So this is a picture of a carpenter who jumped off of a platform and looked down at his foot and started screaming, and was taken to the emergency room, and was in agonizing pain, received opiates, etc. And then they did an X-ray and said, and then they took his shoe off, and it turned out that the nail had gone between his toes. All right, next slide. This is another carpenter who was working with a nail gun, and whether he was also having a little bit of extra lubrication after lunch, I don't know, but he had a mishap with a nail gun. Didn't notice anything for several days. Finally went to a dentist saying, gosh, doc, you got to help me out with this toothache. And then they got that X-ray. All right, next slide. So let's talk a little bit about a subject that we've already broached, which is the notion of what are these diagnoses? Are there actual illnesses that correspond with these somewhat arbitrary constructs that got started with the initial DSM and have been carried over and are now changed in their form. So in terms of construct validity, if you look at page 2 on your outline, one way of thinking about validity is thinking about it in several different perspectives or components of validity. I'm looking about a third of the way down the page, Roman numeral 5, letter A. Thinking about the DSM-4 disorders, we know that there is a correlation between these disorders and a high level of functional deficits and healthcare costs. So they have what the logicians would call convergent validity. So are we talking about something of importance? Well, we are, because it's costly. And then the next step the logicians would take is there an association? We know that there is an association between somatization and other disorders like depression and anxiety. Is somatization just another expression of depression? or anxiety, or is it something different? And in fact, there's enough data to support that there are people who have significant deficits related to somatization or somatoform complaints that do not have comorbid depression and anxiety, to say, is this something specific we're talking about? And it appears that it is. However, the fact that in DSM-4 the diagnoses are to a large extent based on a negative, in other words, they're based on the exclusion of physical findings, we're defining something in a negative which implies that we do not have criterion validity. We don't know exactly what we're talking about because we're trying to define something in as a vacuum or a negative space. And the fact that we are not able to make predictions about future events means that we don't have conceptual validity. So the point that Sandra was making earlier about, what are these disorders and how prevalent are they going to be, how are they going to behave, remains to be determined because we haven't done the research. How often are there things that we call somatoform disorders that are actually medical disorders that just haven't been diagnosed yet? Has anybody had a case like that where they've had somebody referred to them as having a somatoform disorder where you really thought, gosh, I don't know if this doesn't really quite add up?
Well, and that's why psychiatrists can save people's lives. I had a kid referred to me with psychogenic vomiting, and he had a posterior fossa tumor. But it was felt to be psychogenic vomiting because his dad had had a heart attack, and all of a sudden he'd get up in the morning, vomit, and not go to school. So he was staying home to take care of his dad. Had like 3 GI workups, and it's like, well, if you're coming to my unit, let's at least check you out neurologically also. So.
Wow.
Child, 10-year-old boy presenting with conversion diagnosis from 2 very good pediatric neurologists who had congenital dystonia and needed to have deep brain stimulation. These cases permeate the pediatric neurology. I think we've been following a case in Boston at Children's Hospital. A child who was diagnosed at Tufts with mitochondrial disease. Sent to Children's because the gastroenterology consultant, that child, had moved from Tufts to Children's. And a psychiatric consult was obtained, and the child was felt to have Munchausen's by proxy, factitious disorder by proxy. Was admitted against the family's wishes to a psychiatry unit at Boston Children's for about a year. This is not anti-Boston Children's. The Department of Children and Family Services in Massachusetts insisted that they had custody, and they insisted that this kid be incarcerated. It was certainly the way it sounded to me, until a court order finally, just recently, allowed the child to be discharged to a residential treatment center. I make that point only because I think whatever criteria we're ever going to have are never going to be adequate for some of the patients we see where the ambiguities just can't be resolved. And I would guess my adult colleagues feel the same way.
Well, and other than patients admitted to the epilepsy monitoring unit where they are discharged with as clear as kind of a black and white as it can get, either the spells you've had here are epileptic or they're not, everyone else is still a question mark. And everyone else's plan is, I'll continue following up with my doctor. And they usually come back.
And kids with epilepsy are at higher risk to have non-epileptic seizures.
And a third of those patients usually that have non-epileptic spells often have epileptic spells. So even though I say the spells you've had here aren't, sometimes neurologists still say, well, there's still a chance they could be epileptic, so there's still an indication to follow them. So these patients are really medicalized.
And it's all kind of difficult sell to our other medical colleagues to follow along with us.
Yes.
And say, okay, workups, the $1 billion workup's been negative, and we're just having to check in with you every 3 to 6 months. And sometimes I find people accept that as a way for them to maintain their alliance with me. And they say, okay, I'll see you. I know I'm not going to find you. But Sometimes you do. And I believe probably all of us can tell some stories. A 6-year-old evaluated for an odd bent over gait, stance, posture, nobody could explain. Everything's negative. So essentially 6 months later, the retroperitoneal lymphoma is big enough to be found. And if it weren't for that following along, it would not have been found.
The incidence of finding a medical cause for conversion disorder, has gone down from like 30% when I was in undergrad to less than 10% now. So what's happened in the interim is we've gotten better at finding causes,
Earlier
We're not
reports.
perfect at it at all.
The trouble with all of these arguments is that they perpetuate this sort of mind-body duality.
Yeah.
It's not very helpful.
The challenge in neuropsychiatry is that these patients with neurologic symptoms often have abnormal scans that some people feel are absolutely an explanation of causality, but the lesions aren't in time and space in the right place to be causing these symptoms. And then there's this whole idea of cryptic seizures that you can't measure and things like that. I had a lot of, I guess, what we call now somatic symptom disorder patients, probably half of my caseload when I was a fellow, really of any obvious, neurologic explanation for their neurologic symptoms. I had a few with abnormal MRI scans back when we were just getting them all willy-nilly, find a lot of hyperintensities on these things and so forth.
Right.
Yeah, it's interesting. I ran a big mind-body. It turned out to be a mind-body clinic.
Right.
If I look back on it.
Right. And George, back to your point, I think DSM-5 in their narrative talk about how part of the effort in the changes that they've made is to try to lessen the likelihood of resorting to the mind-body duality and trying to provide constructive a constructive diagnostic pathway that allows one to have both, mental health and physiologic medical illness. The case X that I was going to talk about was a outpatient consult referred to me from a family practitioner in the community a year or so ago, and the request on the consult on the referral was, patient seen by a neurologist with neurologic symptoms. I think this is conversion disorder. Please confirm, or something to that effect. And the guy was a 40-some-year-old guy who had been working his whole life, no history of trauma. Came in with his wife. Described having a sudden onset of 3 months of neurologic symptoms, and had a whole variety of neurologic symptoms, paresthesias, weakness, and unsteadiness on his feet. And really was discouraged. He wanted to get back to work, but he'd been laid off because he couldn't perform at his job. He'd seen a couple of neurologists, both of whom thought he had a conversion disorder. In the interview, he appeared impaired to me. He slurred his speech. He had facial asymmetry. And I really was not convinced that he had a conversion disorder, and gave that feedback to the primary care doctor. Now, in fairness, I didn't have a chance to review the information from the neurologists and whether they had seen something which absolutely was, indicative of someone that was having non-physiologic symptoms. And that, I think, is one of the shortcomings of our current system, is that we don't have an automatic, because we're not on one electronic medical platform, not to raise that issue everywhere I go, but I think it is important that as we become more embedded in the primary care world, that we have a way of getting all the information when we make a decision. Let's go on to the. Oh, you're already on the next one.
Steve, your question.
Yeah.
No way to prove any of this. I believe I've seen patients with hysterical conversion that are psychiatric. I think I've seen hysterical psychoses. I think I've certainly seen hysterical dementias. We had a lady, actually, many years ago came here. I believe she had a hysterical personality organization. She showed up 20 years earlier, floridly psychotic, believing she was Princess Diana and she had just died. And she was grieving the loss of her 2 children and how they'd live without her. And all kinds of cray drama. Went away, never came back. And in the meantime, she developed IBS and fibromyalgia and chronic fatigue syndrome, and has possibly got MS, but been with a lot of trauma around, accusing people of stealing from her. And I think if you look at Freud's explanation of conversion, there's no reason to exclude the psychic domain.
Yeah. How many other folks have had patients like that where their somatoform symptoms were essentially psychiatric in nature? Yeah, I certainly feel. Yeah.
Well, and then it's hard to sort out what's malingering also.
I had a young man years ago sent to me from the adolescent clinic when he turned 18, who the first words out of his mouth was, "I see dead people." And it was a year or so later when he finally said, actually I never saw any of this stuff. It was a way for me to have an identity, and you guys, it really got you guys' attention, and So in terms of trying to reach a biopsychosocial understanding of somatoform disorders, there are some biologic correlates. There is some functional imaging. I quoted one study, not of patients diagnosed with somatoform disorder, but of people that had high pain thresholds and low pain thresholds. And there's some differences in terms of the regions of their brain that light up. There may be some neuroimmune correlates in terms of interleukins and neurotrophic factors, that inflammatory processes that get set up that are then able to perpetuate themselves, leading to chronic aches and pains. Cognitive behavioral processes, certainly, I think John's case speaks to the notion of somatic amplification, that you can start to have a symptom and then there's a vicious feedback cycle and a hysterical feedback cycle, and a few missed memory items can turn into a dementia. And that domain is where there may be the best hope of us intervening, within the primary care clinic, in that there is some evidence that cognitive behavioral therapy can be helpful for these folks. Another aspect of this, which I find fascinating, is that of the culture-bound syndromes. And I put down a few of the more interesting ones. If you look on, it looks like page 3, 6C down at the bottom. I think all of us, when we did our med school psychiatry rotation, read about some of these. Running amok, going berserk. I thought that the most interesting on the back of the next page, Stendhal syndrome, palpitations, dizziness, confusion, hallucinations, or syncope in the setting of being overwhelmed by art. I just, I've almost had that myself, so, I can understand that. But
jumping punishment of name used to be listed among the...
Yeah, that's still, I didn't put it in there, but it's still there. And they've found a biological correlate to that. And I don't recall what it is, but there's
physiologic increased star response.
Yeah.
It probably is hardwired.
It's a genetic subpopulation of folks that have that. So what kind of, it's easy to look at these culture-bound syndromes that happen in foreign places and to recognize that there is a culture-bound component to them. What culture-bound syndromes do we have in our culture that we don't even recognize because we're immersed. We don't have objectivity because we're immersed in the culture ourselves.
We have neurasthenia.
Neurasthenia.
We've always had it. It's
Yeah.
still here.
We have road rage, mall shootings.
Yeah.
Well, the guy did cut me off, George.
But conversely, if culturally, if we look at the Asian culture, it's very unusual to have diagnoses of depression and anxiety, yet there's a much greater incidence of somatoform disorders because culturally, understanding distress is understood more physically than emotionally. So I think that getting away from road rage and stuff like that.
I think the other thing to remember about cultural incident is most of the time that I've seen them, other fellow individuals who are in the same culture recognize them as ill and crazy. I mean, it's not like, sometimes we just sort of throw up our hands when we talk about it like, oh, well, that's just what they do in their culture. No, that's what mentally ill people do in their culture, and most of the rest of their culture recognizes it as mentally ill.
But what's really cool is when there's like mass hysteria. Like if there's an odd smell at a school and then all of a sudden everybody has a symptom and it's not based on anything. Yeah.
We have a lot of that.
Sick building syndrome. Yeah.
Neurasthenia had a good prognosis when we called it neurasthenia and gave people milk and fresh air and a lunch share in the yard, but now it's uncurable and it's medicalized, and you used to do Epstein-Barr virus titers, chronic Epstein-Barr,
Don't
was
forget
chronic
Lyme.
systemic candidiasis, and then chronic fatigue syndrome, and the Gulf War syndrome. And it's always kind of marched forward, but each new manifestation we spend more and more money, working it up.
Are you saying you think the prognosis is worse now because what that people really need is permission to be ill for a while and just to kind of just
A little validation, a little plan out of the hole they're in.
6 weeks at a spa. And they're
Yeah.
better.
They
Go
just
to the old mental
marching
health
around to
days from
different doctors.
school.
Ended up
Even all the time
with
during
seronegative
this.
Lyme disease.
What about dissociative identity disorder?
I've seen two variants of that. I think the fake one and the one that I find here called the
And which is more common?
The fake one. I had a lady give me an Excel spreadsheet in Michigan with her 30 alternatives. I said, all right, well, first of all, I'm an adult psychiatrist, so 18 of these people I can't help at all. Little feng shui crisis.
Yeah, I find it striking. 10 years ago, I had lots of folks come to me with the complaint of multiple personalities, and it's been, I haven't had that at all
I
lately.
have a patient who hangs on to that despite, right?
Oh, yeah.
And Dan, we just had the pleasure of taking care of her for a few days on the inpatient unit. But talk about somebody who's got the mush of psychiatric as well as physical somatization as part of her presentation, who also has real life stuff going on.
Yeah.
It's so hard to tease anything out with her.
Yep, that's somebody who uses her somatization as a defense against talking about psychiatric illness, and her psychiatric illness as a defense against talking about
She does.
the medical aspects of her son.
Well, somatic defenses are very primitive. They really are at the lower level. It's when you're able to identify the affect that they're getting better. So she cycles around all directions.
I had a kid in the Air Force who we were sending home. She kind of cycled out of basic training. So they'd come on the psych unit, they'd stay while we got their airplane tickets. And so she was going, which makes them all happy. And she was leaving the next day, and she just approached me on the unit. She was like, really like, kind of in my space and pushy and just dysphoric, and it made absolutely no sense to me. And I went back later, and I'm like, what's going on? What was that about? And she said, what? And I said, well, I described what she did, and she got like embarrassed, and she said, that's weird. Sometimes I do that. I feel like I'm someone else. And she she apologized, but she wasn't like marketing it as a
Right.
calling card.
Right.
So if it exists, I would say she had it.
Right.
But my lady with the spreadsheet, I think that's another story.
Probably didn't.
So
Right.
that sort of gets over into the dissociative disorders.
Yeah.
Right.
Yeah. Sure it
There's
does.
probably a fair bit of overlap.
Sure. All right, next slide, please, Jerry. So this is a slide that I clipped out of the British Medical Journal outlining the whole inflammatory process, or one theory about the inflammatory process and how that might have bearing on somatoform complaints. I'm guessing there are people in the room that know a lot more about cytokines, and et cetera, than I do. But I think that the point is that there may be some physiologic basis for this sort of complaint that we may understand better over the next generation. Next slide, please. Here's a slide also clipped from a article about a kind of therapy for illness anxiety disorder, and the different places where one might attack the assumptions that a person with an illness anxiety disorder might have. Next slide, please. Yeah, we've already talked about that. Next slide, please. In terms of the evaluation, certainly the evaluations are typically going to start in the primary care world and may need to continue. I think it was Doug that pointed out that sometimes what you will want to end up doing is having an agreement that you're going to continue to follow somebody along with their primary care provider, continuing to look for a physiologic basis. There is a screening instrument. Actually, there's several screening instruments. I included one of those in the email, the PHQ-15, and also included the scoring instrument for that. That's not actually not in your written handouts today, but if you check your email, if you're interested in printing that out and using that, it's part of the PHQ system.
Do you know if anybody's using that in primary care?
I'm not aware of anybody here using it in primary care. I mean, it certainly would be something worth considering. I did actually present that to the embedded social workers that I work with, and I got an underwhelmed response from them. They did not, greedily snatch it up, looking like they were going to go back and use it. But I think if you were a primary care provider and you were looking for some sort of a process to call out folks that you were going to then refer for further evaluation, it might be a useful instrument. And then so certainly the third part of the evaluation might be a psychiatric evaluation in which it's important to look for the somatoform disorders, but also for the high level of comorbidities.
I think that the balance here, the challenge is not going overboard on the medical piece of it, because, most of the common complaints that get presented in primary care, ultimately there's not a medical cause found, right? So you can chase these a long time and in a very expensive way when you really should be addressing it in a more psychosocial treatment format. So where you want to be sure you don't miss anything on the one hand, on the other hand, you don't want to necessarily send people to 12 different specialists before you say, nope, it's just psychiatric, it's just psychological. With the risk with the risk of harm that comes with that. So there are a lot of GI specialists, who would say 80% of what they see is stress-related GI symptoms. There's nothing to be found by the time they get to them.
Right.
And in the hospital, we so often have discussions with the family along with the medical provider that you can always do more tests. There are always more tests you can do. But when does it become traumatic to the child? And when does it stretch medical judgment to go yet further, recognizing that we may not find the answer to your child's whatever it might be, pain, etc. And it's very, very important to do that in collaboration with our primary care colleagues if it's outpatient and our specialty colleagues if it's inpatient. I'm sure that's another thing that comes up across the age span.
As we enter the age of personalized genomics, that question is going to be even more relevant.
I think so.
Because the temptation is going to be to look for the...
Let's go into the last slide, please. So and Cindy, your perspective, I think, is an excellent one and is well represented in the attachment that's labeled Primary Care Management Strategies. That's in your email. That comes from the American Journal of Family Practice, and essentially, says you want to identify early folks that you think of as having potential somatoform processes, and not do extraneous tests. But you also want to legitimize the fact that they're suffering and that they can have both mental and medical problems. And there's some other strategies, including seeing people frequently for short visits, et cetera, that I think most of us are familiar with. But that sending that to a primary care provider actually may be quite helpful because they may not be as familiar with that notion of how to manage a person in their practice. Beyond that, the notion of using CBT, which has a fair amount of evidence in the literature that it can be helpful for somatoform disorders, that may be a logical extension of what we're doing in terms of our integrated program, where we've got now embedded clinicians that are starting to do CBT, for depression and anxiety, but there's a specific kind of CBT for somatoform disorders that may, pay off in an accountable care paradigm. Yeah, Dan.
I'm almost always the pessimist, but I guess I feel like there's at least two subsets of folks here. I mean, there's people who are able to take in some fashion the somatoform paradigm, and people who, if that's what you're talking about, then I'm just going to the next doctor.
Yeah.
And I'm curious about what we know about the demographics, the numbers on that. I mean, if you get people who are willing to join a CBT study, willing to consider that then you probably are going to have some kind of high success rate. But what do you do with all those other folks who see that as just being, not listened to, harmed out, disregarded?
One strategy you could consider, and I don't know if this is being done here anywhere, or for other kinds of patients, is mindfulness-based training. And that can work, regardless of what and John Kabat-Zinn's training uses it a lot for patients with cardiovascular disease and other pain symptoms and things like that. It can be very effective, and the patient doesn't have to accept that they have a somatoform disorder for it to work. Actually.
No, I mean, a lot of it is in the delivery, where you validate their experience and say, you have to live with this whether we find it cause for it or not, and in the meantime, how can we help you to live with it? And it's usually looking at CBT and looking at mindfulness, and because you want to have a life even though you have these symptoms. So my experience is that very few people stop coming if it's delivered in that way because they are hurt. It's when you do the full biologic workup, and then after they've seen 12 other specialists, then they say, now you have to see the psychiatrist. That's the setup, where it's like, that makes our job pretty challenging, doable, but challenging.
My advantage when I was a fellow was that they'd see the I was the end of the line, the neuropsychiatrist, and they came with the expectation I was going to connect the brain problem. And it was easy then, because I didn't have to say, well, no, I can't, so I'm going to send you to see Dr. Boyack to talk about, psychiatric elements here. And most of them ended up staying. I didn't know what to do at the time. I just did supportive psychotherapy, sucks to be in therapy sort of thing. They came, they stayed, they were grateful, they twitched.
And they were probably a little better.
Lived their lives,
And we sometimes talk about the risk factors of CBT are much lower than another surgery or more medications. And so to get them to the office and to get them to follow those referrals, and sometimes we couch it as well as, this is not instead of your treatment with the medical team, it's in addition to, but then also it's, it sucks to be you, so why not see someone about, the process of finding what eventually you believe will be medical, but, talk to someone about that process of, you're sick and you're in the hospital. But I wish we had data on, we just see the people that keep coming back because they haven't taken a fuss on their referral, so they continue to have surgery, and then later adhesions and other problems, but I don't know if anyone actually takes a supplement.
No, there's, the vast majority, I think, do take the, it sucks to be you. We don't know what to call this, but in the meantime, let's get you some support. But there are the people that say support, screw that, like I'm moving on. And I think in the inpatient setting, that there is that subset of people that are just not following up with anybody no matter what, like no matter how, at least,
Right, yeah.
it's not going to happen. They'll come back.
Some of them have this weird nobility with pursuing the diagnosis and getting tested, and I think giving that up, they like mourn it like it's a death.
Well, that's
Just
why
don't think I'll talk to
neurologists
somebody.
have come up, actually, they printed out brochures that they've given us that we give to patients called psychogenic non-epileptic spells. So it's PNES, and that's what I have, and this is my
It's a
diagnosis, and I have a brochure about it.
There'll be a pill for that soon.
Yeah.
Yes.
All right, thank you, everybody.
Yeah, thank you,
Thank you,
Steve.
Steve, that was wonderful.
Thank you.
Thanks.
Thanks for the handouts, too.
Sure.
For feeding us.
Yeah, oh yeah, take some chocolate. If you haven't got your chocolate reward, go ahead and get that. Everyone gets one.